Listen carefully. One small rhythm mistake in the heart can become a big exam question. Today, we start BNF Chapter 2. In this video, we begin with arrhythmias, BNF Chapter 2, Part 1. I'll explain it slowly, clearly, and exam-focused. So stay with me. Let's begin. All right, students, take a deep breath. This is an important cardiovascular topic, small in notes, but very powerful in exams. Today, we're going to understand arrhythmias, not just definitions, but how to think clinically. Listen carefully. What are arrhythmias? First, the basics. Arrhythmias mean abnormal heart rhythms. That's it. But what does abnormal actually mean? It can be the heart beating too fast, the heart beating too slow, or the rhythm being irregular. So remember this line clearly. Arrhythmia equals problem with heart rhythm and not heart strength. This distinction is very important. Now, students, this part is exam gold. Managing arrhythmias never starts with drugs. It starts with diagnosis. Step 1, correct diagnosis. You must know which arrhythmia it is because treating the wrong rhythm can make the patient worse. Step 2, ECG is essential. Let me say this clearly. Never treat arrhythmias blindly. No ECG equals no confidence. ECG tells you rate, rhythm, origin of the problem. Without ECG, you are guessing, and guessing is dangerous. Step 3, treat the underlying cause. This is where many students make mistakes. Arrhythmias are often secondary problems. Common underlying causes include heart failure, electrolyte imbalance, especially potassium and magnesium, ischemia, reduced blood supply to the heart. So always ask, why did this arrhythmia happen? Listen carefully. Treating the rhythm without treating the cause equals failure. You can suppress the rhythm temporarily, but if the cause remains, the arrhythmia will come back. This sentence alone can save exam marks and patience. Now let's move to a common finding. What are ectopic beats? Ectopic beats are extra heartbeats originating outside the normal pacemaker. Patients often describe them as missed beats, skipped beats, sudden thumps in the chest, when no treatment is needed. If ectopic beats occur spontaneously, the patient has a normal heart, no structural heart disease. Then remember, no treatment is required. Reassurance is enough. This is very important. Not every arrhythmia needs a drug. Sometimes the best treatment is explanation, reassurance, reducing anxiety, when treatment may be needed. Now, treatment is considered only if ectopic beats are frequent, disturbing, symptomatic, causing palpitations, causing discomfort, affecting quality of life. In these cases, beta blockers may help. Why beta blockers? Because they reduce sympathetic activity, they reduce heart irritability, they reduce symptoms safely, and most importantly, they are safer than other suppressant antiarrhythmic drugs. Always remember this hierarchy. Start simple. Start safe. Avoid aggressive drugs unless necessary. Remember this flow. Arrhythmia detected, ECG, find cause, then treat rhythm if needed. If you write this logic in exams, you will always score. Okay, next, atrial fibrillation. First, the basics. Atrial fibrillation, or AF, is a problem with how the atria beat. The atria don't contract normally, they quiver or fibrillate. This causes the ventricles to beat. So remember this line clearly. AF equals atria quiver, irregular ventricular rhythm. This is very important. This is not having treatment goals. Now, students, treatment in AF is always guided by two main goals: reduce symptoms, palpitations, fatigue, shortness of breath, prevent complications. Most importantly, stroke. Also prevent other thromboembolic events. Every AF patient must first be assessed for stroke risk, thromboembolism risk. This assessment comes before any drugs are started. Never skip this step. Management strategies in AF. There are two main strategies to manage AF. 1, rate control. Focus on controlling heart rate. Accept that the patient is in AF, often first choice for older or asymptomatic patients. 2, rhythm control. Focus on restoring normal sinus rhythm. Maintain sinus rhythm long term, often used in younger or symptomatic patients. Let me say this clearly. Always start with the patient's symptoms and stability before deciding the strategy. If symptoms are not controlled or return after cardioversion, refer within 4 weeks. Consider ablation if drugs fail or are unsuitable. Acute presentation of AF. AF can present suddenly. We classify acute AF into unstable and stable presentations. Life-threatening instability occurs if the patient has shock, severe hypotension, acute pulmonary edema. In such cases, immediate electrical cardioversion is required. Do not delay for anticoagulation. Stable acute AF is different. If onset is less than 48 hours, you can use rate or rhythm control. If onset is more than 48 hours or unknown, rate control is preferred. Urgent rate control in acute AF. The drugs used are IV beta blocker or verapamil, only if LVEF 40%. Caution: avoid calcium channel blockers if acute decompensated heart failure is suspected. Always seek senior advice if unsure. Cardioversion. There are two main methods: electrical cardioversion, pharmacological cardioversion. Drugs used for pharmacological cardioversion: flecainide, only if there is no structural heart disease. Amiodarone, safe even with structural heart disease. If AF has lasted more than 48 hours, electrical cardioversion is preferred. Must anticoagulate for at least 3 weeks before cardioversion. If anticoagulation cannot be given immediately, rule out left atrial thrombus first. Start heparin immediately. Continue oral anticoagulation for at least 4 weeks. While waiting, rate control must continue. Drug treatment in AF. Let's start with rate control, the first-line treatment in most patients. Beta blocker, avoid sotalol. Diltiazem or verapamil. The choice depends on symptoms, heart rate, comorbidities, patient preference. Digoxin, only use if the patient is sedentary, if AF is non-paroxysmal, or if other drugs are unsuitable. Combination therapy: if one drug fails, combine any two: beta blocker, digoxin, diltiazem. If still uncontrolled, switch to rhythm control. Caution: if LVEF 40%, prefer beta blocker plus digoxin. Rhythm control drugs. First line, standard beta blocker. If ineffective, amiodarone, flecainide, propafenone, sotalol. Caution: flecainide and propafenone should not be used in ischemic or structural heart disease. Next, a little extra knowledge: anticoagulation and stroke prevention risk assessment is essential. CHA-DS2 VAS-C, stroke risk, orbit, bleeding risk. Let me say this clearly: do not withhold anticoagulation because of old age or fall risk. When to anticoagulate: CHA-DS2 VAS-C coins 2, anticoagulate. Men with score equals 1, consider anticoagulation. Low risk, no anticoagulation but review later. Preferred drugs: non-valvular AF, apixaban, dabigatran, edoxaban, rivaroxaban. If these are unsuitable, warfarin. Aspirin alone is not recommended. Just know these points. Don't overthink it. Okay, next, atrial flutter. First, the basics. Atrial flutter is similar to atrial fibrillation, but the atrial activity is more organized. However, remember this clearly: drug response in atrial flutter is poorer than AF. This is a very important exam point. Rate control in atrial flutter. Rate control is still needed. Drugs used include beta blockers, diltiazem, verapamil, digoxin if needed. But remember, rate control is often less effective than in AF. Rhythm control in atrial flutter. Rhythm control is usually more successful. Options include electrical cardioversion, catheter ablation. Let me say this clearly: catheter ablation is preferred for recurrent atrial flutter because it is highly effective and often curative. Paroxysmal supraventricular tachycardia, PSVT. Now move to PSVT. PSVT is usually due to re-entry circuits above the ventricles. It presents with sudden onset and sudden termination of tachycardia. First step, non-drug measures. Always start simple. First, try vagal maneuvers. Valsalva maneuver, ice-cold water to the face, carotid sinus massage. Important caution: carotid massage must be done with ECG monitoring, avoiding carotid artery disease. If vagal maneuvers fail, next step, IV adenosine. Adenosine is fast-acting and often terminates PSVT immediately. If adenosine is contraindicated, use IV verapamil. But remember this safety rule: avoid verapamil if the patient recently received a beta blocker. Arrhythmias after myocardial infarction. Now, a very dangerous situation. Arrhythmias after MI are high risk. First rule, always get an ECG first, never guess. Second rule, avoid blind use of anti-arrhythmic drugs because some drugs can worsen outcomes after MI. Bradycardia after MI. If the patient develops bradycardia, if atropine is first line, if bradycardia is severe or unresponsive, adrenaline infusion may be required. Ventricular tachycardia, VT. Now students, pay attention. VT is life-threatening until proven otherwise. Pulseless VT or ventricular fibrillation. If there is no pulse, immediate resuscitation. Follow advanced life support protocols. No delay, no drugs first, shock saves lives. Unstable VT. If the patient is unstable, hypotension, chest pain, heart failure, altered consciousness. Then immediate DC cardioversion. If needed, IV amiodarone can be given. Stable VT. If the patient is stable, IV amiodarone is preferred. Alternatives include lidocaine, flecainide. But remember this clearly: all patients with VT require specialist referral. always Torsades de pointes. Now, a very specific ventricular arrhythmia, Torsades de pointes, is associated with prolonged QT interval, often caused by drugs, electrolyte disturbances, treatment of Torsades, first-line treatment, IV magnesium sulfate, even if magnesium level is normal, additional measures, beta blocker cardiac pacing if needed. Very important warning, many anti-arrhythmic drugs can worsen QT prolongation, so be extremely careful. Anti-arrhythmic drugs classification. Now the exam-friendly part, the Vaughan-Williams classification. Class 1, sodium channel blockers, lidocaine, flecainide. Class 2, beta blockers. Class 3, potassium channel blockers, amiodarone, sotalol. Class 4, calcium channel blockers, verapamil. Important safety notes. Let me say this clearly. Anti-arrhythmic drugs can be pro-arrhythmic. Hypokalemia increases this risk. Always correct electrolytes first. Final takeaway, student tip. Remember these golden rules. Always do an ECG first. Rate control is the default strategy. Anticoagulation saves lives. Amiodarone is powerful, but a specialist drug. Never forget stroke prevention. If you remember this logic, you will manage arrhythmias safely and score well in exams. So students, take a breath. This topic looks heavy, but you handled it step by step. If you understand the logic, arrhythmias are no longer scary. Before you go, if this video helped you even a little, like it. Share it with one friend who's struggling, and subscribe so we keep studying together one topic at a time. Next video, bleeding disorders. Stay consistent. You're doing better than you think.